Hello and welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the hosts of the GP Notebook study groups. Now, in this episode, I want to discuss a topic that's been quietly evolving in clinical medicine, but is becoming increasingly difficult to ignore: the misuse of anabolic androgenic steroids, often simply just known as anabolic steroids. You're now likely to have patients on your practice list who are misusing steroids, and it's equally likely that you may be unaware of who they are, and this is no longer an issue confined to elite athletes or doping scandals. What we're now seeing is a broader, more complex public health problem, one that intersects with endocrinology, cardiology, and psychiatry. Now, the global lifetime prevalence rate of anabolic steroid use is around 3%, but among bodybuilders, weightlifters, and elite powerlifters, the rates can be as high as 80%. In the UK, it's believed that 500,000 people now abuse steroids, with some estimates putting it as high as twice this number. And while earlier patterns of steroid use were closely tied to competitive sports, more recent data suggests this has diffused into the general population, particularly among young men engaged in gym culture. And what's particularly striking here is the motivation behind steroid use. Increasingly, these are not sportsmen trying to win competitions. They're members of the public trying to look a certain way, and the emphasis has shifted towards aesthetics, body image, and perceived physical adequacy, with a rise in recent years of the problem of body dysmorphic disorder. Most users of anabolic steroids now seek improved muscle appearance, strength, or performance, while some are trying to improve their self-esteem or well-being. And this change in motivation has expanded the at-risk population and made detection more challenging, because many users don't see themselves as engaging in substance misuse, and access to steroids remains widespread, typically online and through informal gym networks. The term anabolic androgenic steroid covers drugs designed to increase androgenic action by direct administration of testosterone or its derivatives, or by using drugs that increase endogenous testosterone production, such as by increasing luteinizing hormone that then acts on Leydig cells to produce testosterone. Now, as we know, testosterone therapy is prescribed for things like hypogonadism, delayed puberty, and certain catabolic states. But what sets therapeutic use apart from misuse is dose, intent, and supervision. In non-medical settings, individuals are often using supraphysiologic doses, combining multiple agents, and doing so without any clinical oversight, or sometimes even a clear understanding as to what they're using. And it's a salutary fact that anabolic steroids are typically used at doses 10 to 100 times higher than those required to treat medical conditions. Now, from a diagnostic standpoint, it's worth noting that the Diagnostic and Statistic Manual of Mental Disorders 5th edition does not recognize anabolic steroid use as its own discrete disorder. Instead, problematic use is typically categorized under other or unknown substance use disorder, with specification of anabolic steroids, and that alone hints at a broader issue. This is a condition that doesn't always fit neatly into our existing diagnostic frameworks. And this brings us to its etiology, which is multifactorial and deeply rooted in both psychological and social dynamics. Now, one of the most important contributing factors here, and which has been on the rise in the last decade, is muscle dysmorphia. And this is a condition where individuals perceive themselves as insufficiently muscular, regardless of their actual physique, and this often precedes steroid use, driving escalation over time. There's also a strong cultural component, as in certain environments such as bodybuilding communities, combat sports and nightlife security, there can be implicit or explicit pressure to maintain a certain physique. And language such as gear or juice normalizes steroid use and minimizes perceived risk. There's also the issue of reinforcement here. The early effects of anabolic steroid use, such as rapid muscle gain, increased strength, and social validation, can be very powerful, particularly in impressionable young men. And these changes reinforce continued use, even if individuals are aware of the potential harm they're causing to themselves. Over time, this pattern begins to resemble what we would recognize in other substance use disorders: tolerance, dependence, and withdrawal. Now, from a pathophysiological standpoint, the effects are extensive, and one of the most consistent findings is suppression of the hypothalamic pituitary gonadal axis. Exogenous androgens essentially shut down endogenous testosterone production, and clinically this then manifests as hypogonadism, which can persist long after steroid cessation. So how does this present to us in clinical practice? Well, as GPs, we should suspect anabolic steroid use in a muscular man who presents with concerns of infertility, gynecomastia, or evaluation for testosterone supplementation. In women, the effects tend to reflect virilization, so this can include hirsutism, acne, deepening of the voice, and amenorrhea. Some of these changes, particularly voice deepening, may be irreversible. Many people who use anabolic steroids do not seek medical advice or treatment for health conditions potentially associated with their use, and so users will often live with numerous cosmetic, endocrine, and hepatic toxicities, seeking help only if these seem worse than coaches or peers told them to expect, or if their symptoms don't abate after decreasing or stopping their steroid use. These patients almost never come into our surgeries saying they're using anabolic steroids. Instead, they present with complications, and we have to try to tease out what's happening from taking a careful and non-judgmental history. So, this could be a young man with unexplained gynecomastia, a recreational gym user with new onset hypertension or dyslipidemia, or a patient with mood instability or depressive symptoms that don't quite fit a typical pattern. So the most useful tool for diagnosis is to ask about the use of steroids in that non-judgmental way. And a suggested approach is to ask about the frequency and intensity of training sessions, the goals of such training, their perceptions of their body image, and if they've been offered or used steroids. In those who then state that they do use them, attempt to establish the substances involved, as long as the duration and pattern of use, including the mode of administration, which are typically oral or injections. Now, in most people, regular doses of anabolic steroids will produce well-recognized physical changes. In men, we see acne, oily skin, excessive muscular development, changes in libido and testicular atrophy, erectile dysfunction, infertility, temporal hairline recession, and gynecomastia. In women, we also see acne, oily skin, muscular development, menstrual irregularities, and changes in libido. The potential irreversible masculinizing effects include hirsutism, male pattern baldness, deepening of the voice, and clitoral hypertrophy. Unfortunately, there is no practical diagnostic test to detect anabolic steroid use in the general population. Because steroids suppress circulating gonadotrophin concentrations, the most useful of the commonly available tests are measurements of serum testosterone, follicle-stimulating hormone, and luteinizing hormone concentrations. A suppressed luteinizing hormone, elevated hematocrit, and low sex hormone binding globulin should raise suspicion. But the bottom line here is that diagnosis ultimately depends on a careful, non-judgmental history. In men, you may see reduced testicular volume, low sperm counts, and infertility. And recovery can take months or sometimes even longer and is less predictable in older individuals or those with prolonged exposure to anabolic steroids. Cardiovascular effects are a major concern here. Anabolic androgenic steroid use enhances vascular resistance and blood pressure and the pro-inflammatory biomarker profile. It alters serum lipoproteins by elevating LDL and reducing HDL levels, and produces direct myocardial toxicity. In fact, cardiac complications are the major cause of sudden and premature death associated with anabolic steroid use, and cardiomyopathy can result from remodeling after myocyte injury. Neuropsychiatric effects are equally important. Anabolic steroid exposure can alter neurotransmitter systems involved in mood and reward processing. So clinically, this may present as irritability, aggression, mood swings, depressive symptoms, or even full-blown mania. There's also now evidence linking steroid misuse to increased risk-taking behavior and sometimes even criminal activity. When it comes to management here, the cornerstone is cessation, but that's often much easier said than done, as many patients are reluctant to stop, particularly if they're experiencing perceived benefits or fear losing their muscle mass. Withdrawal is also a significant issue, and symptoms here can include fatigue, insomnia, reduced libido, and, notably, depression. And in some cases, depressive symptoms can be severe and may include suicidal ideation, which makes close monitoring essential. There's no universally accepted treatment, but it's vital to address the psychological component here. And cognitive behavioral therapy can be helpful, particularly in individuals with underlying body image concerns. Screening for co-occurring substance use is also critical, as anabolic steroid misuse often overlaps with other risk behaviors. After stopping them, changes in hormones, lipid and cholesterol metabolism, and salt and water balance typically resolve within weeks to months, but muscle tone will start to decrease even with continued resistance training. Patients may also notice decreased stamina and decreased exercise tolerance, and some may actually have a withdrawal-associated dysphoria, which could prompt a relapse. I suppose one of our biggest challenges in practice is recognition. Because anabolic steroid misuse spans multiple specialties, it can easily fall through the cracks, so a cardiologist may treat the heart disease without identifying the underlying cause, and a psychiatrist may address mood symptoms without recognizing the hormonal contribution. It therefore remains the case that awareness is the key here, asking the right questions, being attuned to subtle clinical signs, and maintaining a high index of suspicion in at-risk populations can all make a significant difference. So just to pull this all together, anabolic androgenic steroid misuse is a complex, multifaceted condition that is more common than many clinicians realize. and it sits at the intersection of physical health, mental health, and socio-cultural influence. And while it may not yet have a clearly defined place in our diagnostic systems, its impact on our patients is very real. So as GPs, our role is not only to treat the complications, but to recognize the underlying patterns, engage our patients in open conversation, and guide them towards safer, evidence-based care. So that's a quick overview of anabolic steroid misuse, and I do hope you found this podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.